Welcome to this comprehensive guide on acute myocardial infarction, or AMI. Whether you are a medical student, healthcare professional, or just someone interested in understanding heart attacks, this video will provide a structured, evidence-based approach to the topic. We will cover the diagnosis, management, complications, and therapy strategies for AMI, ensuring that you leave with a strong understanding of this critical condition. Let's get started. Acute myocardial infarction, commonly known as a heart attack, is a life-threatening condition caused by prolonged ischemia due to reduced or completely blocked coronary artery blood flow, leading to myocardial necrosis. AMI is a subset of acute coronary syndrome and is classified into ST elevation myocardial infarction and non-ST elevation myocardial infarction based on ECG findings. STEMI involves a complete coronary occlusion with ST segment elevation on ECG, while NSTEMI is due to partial occlusion with no ST segment elevation, but with positive cardiac biomarkers indicating myocardial damage. Acute myocardial infarction occurs when a coronary artery is obstructed, leading to an imbalance between oxygen supply and myocardial demand, resulting in irreversible damage to cardiac muscle cells. The most common cause is the rupture of an atherosclerotic plaque, which triggers thrombus formation, leading to occlusion of blood flow in the affected coronary artery. This blockage deprives the myocardium of oxygen and nutrients, ultimately causing ischemia and myocardial necrosis. STEMI occurs due to the complete occlusion of a coronary artery, leading to full-thickness myocardial necrosis. It is characterized by ST segment elevation on an ECG in at least 2 contiguous leads, indicating severe ischemia. Because STEMI represents an acute and life-threatening condition, it requires immediate reperfusion therapy, either through primary percutaneous coronary intervention or fibrinolysis, to restore blood flow and minimize heart muscle damage. NSTEMI occurs due to the partial occlusion of a coronary artery, leading to subendocardial myocardial necrosis. Unlike STEMI, ECG findings do not show ST segment elevation, but may present with ST depression, T-wave inversions, or a normal ECG. The management of NSTEMI focuses on early risk stratification to determine the severity of ischemia, followed by coronary angiography to assess the need for revascularization. The symptoms of acute myocardial infarction can vary, but the classic signs typically include chest pain or discomfort. However, atypical presentations are more common in elderly patients, diabetics, and women, and may present as epigastric pain, fatigue, palpitations, or silent infarctions without typical chest pain. Recognizing these variations is crucial for early diagnosis and timely management. The diagnosis of acute myocardial infarction is based on the universal definition of myocardial infarction, which requires the elevation of cardiac biomarkers, specifically troponin T and I, with at least one value above the 99th percentile. Additionally, at least one other diagnostic criterion must be met to confirm AMI. The diagnosis of acute myocardial infarction relies on several laboratory and imaging tests. The electrocardiogram is the first-line test used to differentiate STEMI from NSTEMI based on ST segment changes. Cardiac biomarkers, particularly troponin T and I, help confirm myocardial injury. Echocardiography is used to assess left ventricular function and detect wall motion abnormalities, which indicate areas of ischemia or infarction. Coronary angiography is the gold standard for identifying culprit lesions and determining the need for percutaneous coronary intervention or coronary artery bypass grafting. These diagnostic tools play a vital role in guiding treatment decisions for AMI patients. Emergency treatment for acute myocardial infarction follows the Monabie approach, which includes morphine, oxygen, nitrates, aspirin, and beta blockers. Morphine is used for pain relief and anxiety reduction, while oxygen is administered if oxygen saturation is below 90%. Nitrates help reduce myocardial oxygen demand, but should be avoided in hypotension and right ventricular infarction. Aspirin is given as a loading dose 162 to 325 milligrams to prevent further clot formation. Lastly, beta blockers are used to reduce myocardial workload and the risk of arrhythmias, unless contraindicated. These initial interventions help stabilize the patient and improve outcomes in AMI management. The preferred treatment for ST elevation myocardial infarction is primary percutaneous coronary intervention, which should be performed within 90 minutes of first medical contact. This approach helps rapidly restore blood flow and minimize myocardial damage. However, if PCI is unavailable within 120 minutes, fibrinolytic therapy with alteplase or tenecteplase is administered to dissolve the clot and re-establish coronary perfusion. Timely intervention is crucial to reducing complications and improving survival outcomes in STEMI patients. Management of non-ST elevation myocardial infarction involves early coronary angiography within 24 to 48 hours for high-risk patients to assess coronary artery blockages and determine the need for revascularization. In addition to invasive evaluation, medical management plays a crucial role and includes dual antiplatelet therapy, anticoagulants, beta blockers, and statins to reduce thrombotic risk, prevent further ischemia, and optimize long-term cardiovascular outcomes. Acute myocardial infarction can lead to several life-threatening complications. Cardiogenic shock occurs due to severe heart failure, resulting in hypotension and organ hypoperfusion. Arrhythmias, including ventricular fibrillation, atrial fibrillation, and bradyarrhythmias, are common and can be fatal. Heart failure develops when extensive myocardial damage reduces the heart's ability to pump effectively. Mechanical complications, such as ventricular septal rupture, papillary muscle rupture, or free wall rupture, can cause catastrophic deterioration. Lastly, pericarditis at Dressler's syndrome is an immune-mediated inflammatory response occurring after MI, leading to post-MI pericarditis. Early recognition and management of these complications are crucial to improving patient outcomes. After an AMI, long-term management is essential to prevent recurrence and improve survival. Dual antiplatelet therapy, consisting of aspirin plus a P2Y12 inhibitor, clopidogrel, ticagrelor, is recommended for at least 12 months to prevent thrombotic events. Beta blockers are used to reduce mortality and prevent arrhythmias by decreasing myocardial oxygen demand. ACE inhibitors or ARBs help prevent cardiac remodeling and lower the risk of heart failure. High-intensity statins play a key role in reducing LDL cholesterol levels and preventing future plaque rupture. Finally, lifestyle modifications, including smoking cessation, regular exercise, weight management, and dietary changes, are crucial in maintaining cardiovascular health and reducing long-term risks. The prognosis of AMI depends on several key factors. Time to reperfusion plays a crucial role, as earlier intervention improves survival rates by restoring blood flow and minimizing myocardial damage. The extent of myocardial damage also affects outcomes. Larger infarctions increase the risk of heart failure and sudden cardiac death. The presence of comorbidities such as diabetes, kidney disease, and prior MI worsens prognosis by complicating management and increasing cardiovascular risk. Additionally, adherence to secondary prevention measures, including medication compliance and lifestyle changes, significantly reduces the likelihood of recurrent events and improves long-term survival. Okay, just a quick recap. AMI is a medical emergency that requires rapid recognition, immediate treatment, and long-term management to reduce mortality and improve quality of life. Early intervention with PCI, alongside appropriate medication therapy and lifestyle modifications, plays a vital role in preventing complications and enhancing survival outcomes. Effective management strategies, including dual antiplatelet therapy, beta blockers, statins, and ACE inhibitors, combined with smoking cessation, exercise, and dietary changes, can significantly reduce the risk of recurrent cardiac events. Thank you for watching, and stay tuned for more upcoming videos.